it's the battery is flat. So just very briefly on the very important outcome of lung function. So basically in our group there was no doubt that we should measure lung function at an outcome in clinical trials for TB and post-TB lung disease, and we also made the point again that it should actually also happen for TB trials, so for drug trials, etc., and not only for post-TB trials, and that was a bit a vague formulation of the question, so we had discussed that before. And then discussing what we should measure, there was a wide consensus that we should do spirometry with the usual FEV1 and FVC. We thought about the small airways, but there's no data, so the FEF 25 to 75 and also maybe FEV 3 and 6 seconds. There was for the small airways really advocates to use oscillometry, and there will be more data. We also brainstormed about the peak expiratory flow, but also concluded that this is basically included in the spirometry. Yeah. And we also said that really FEV1 as a key marker should be in all TB trials. So, and the others are not really secondary, but that should be the prioritized marker by our knowledge. We briefly had a discussion about quality assessment of lung function, and because we all know that with more practice it gets better in spirometry, but also in the other lung functions, the outcomes. So in terms of rating of the quality criteria, according to the latest spirometry guidelines, it should be ideally group A, B, and C. How much is okay? Yeah, good. And we also agreed that, of course, we had a quick vote in our group that body box, so body plethysmography, or even multi-pref washout with, for instance, EZ1 Pro is difficult to access in many sites which have limited resources. And then there was the interesting thought to have really participants trained before they do spirometry, so have training and then come back after they had training for the actual trial assessment.
All right,
yeah.
Thanks.
That's good? Okay.
All right, thanks, Gunnar. Group 2, functional status. We have a mic now.
1 minute. Right. So the conclusion was from functional status was that there's some confusion over the definition of functional status is the first problem, but overall that it is an important outcome because people need to function and not just be alive. Some of the functional status sort of measurements we discussed very much, I think there was a sort of feeling that this did depend on the research question somewhat. We discussed the 6-minute walk test, but also discussed its issues. So discussed, for example, using the incremental shuttle test to try and get over the ceiling of the 6-minute walk test, but also discussed the benefits of the 6-minute walk test and basically didn't come to a full consensus on which to use. We also discussed sit to stand, grip strength as a functional as a proxy for functional status. And that was the sort of general discussion, and we have not come to a consensus on which is the best test to use, partly because of the definitions of functional status, and when to measure it, also not fully hit consensus, but concern over the burden of testing too regularly versus the need to test regularly for research purposes. And just to be super clear that the main priority is we think we need to ask the patients who we didn't have in our group what their main need is for functional status.
Thank you so much. Thanks so much, Becky. Let's quickly move on to patient-reported outcomes.
So we split into two groups actually to discuss this, but I'll just quickly go. I think our group agreed that it's really important to measure patient-reported outcomes. This is what we're trying to achieve through all of our interventions, improving how people feel. There was some concern about using it as a primary outcome, just because sometimes symptoms are very difficult to measure and compare between populations and even within individuals over time. And we don't know how they correlate with physiology, imaging, clinical outcomes often, but definitely important to measure. We discussed whether you would ask people about symptoms now versus change in their symptoms over time, and discussed using things like patient diaries to sort of document change over time and exacerbations, and agreed that whatever symptoms you choose to measure have to be relevant, of course, to the intervention that you're putting in place. And then lastly, in terms of what symptoms you measure, I think there was broad agreement that it would be helpful to align with TB trials and also with broader respiratory intervention studies, but that we wanted to capture breadth of symptoms. And so while something like MMRC would be useful, it's maybe quite narrow in its focus, and a composite sort of symptom score is useful. We didn't decide which one, but agreed that whatever we do use should be validated and translated.
All right, thank you so much. Quickly over to lung imaging. Oh.
I have perhaps just one thing to add to that. We agreed with all of that. And we had some people say that they've used the SGRQ and found it very difficult to use in typical populations that typically have post-TB lung disease. Yep. But also that it gives a very nuanced overview of the different spheres of impairment that we want that information. So the suggestion was that we need to spend more time as a group validating the SGRQ and perhaps adapting it and then validating the adaptation in our own communities to make it useful.
All right, thank you so much. We are over time, so very quickly, can we get a 30-second summary, sorry, from lung imaging?
Okay, in short, lung imaging, we all agree that it should be included in all trials. We made some distinction between early trials in which a CT we think is preferable. In 30 seconds we can't say what one needs to measure, but it gives a lot of information, including mechanistic information. It may not have to be the primary outcome in your trials, and then later phase 3 and 4 trials will need to have something that's more accessible, like chest x-ray with some basic measurements. Nice things about imaging is it is in some ways easier and less user-dependent compared to patient outcomes and even spirometry, and so it's a bit more reproducible, and it can that's why it's more appropriate for your early trials with smaller sample sizes.
All right, thank you. And 30 seconds for healthcare utilization.
And because it's important for patient and it's important for resource allocations, and how to measure is it should be measured in over certain period, like for example like 2 years. And the big thing to be considered is that like we need to be context specified, because every country has like different accessibility to the healthcare systems. And we also mentioned about the how to measure exacerbations, for example like presentation for cares, or outpatient visits or inpatient visits, level of cares, and or accessibility to healthcare. And also hospitalizations for frequencies, duration, or time to discharge.
All right, wonderful. Thank you so much. So clearly there's a lot more work to be done. We will be forming a working group that is planning to meet post-symposium. If you're interested, please sign up in the sheets that were shared with all of your groups. But otherwise, thank you very much for your input, and have a wonderful rest of the day. And also, a housekeeping message. Please come back here at 2 o'clock for the closing session. Please don't run away.
If you were part of the PTLD working group, stay in here for a quick picture.